Hello, everyone. Once again, welcome to today's webinar, Ill-Gotten Gains, the Inequity of Rising Medical Debt and How States Can Respond. I'm Manasa Kona, an assistant research professor at Georgetown University Center on Health Insurance Reform. Today's webinar is brought to you by Healthcare Value Hub and with support from Robert Wood Johnson and Arnold Ventures. They review evidence to identify policies and practices that work best and provide free resources, particularly to consumer advocates across the U.S. They also provide state technical assistance to support consumer advocates working at the state level to pass policies that can make healthcare systems more equitable, affordable, and patient-centered. As I mentioned, I am Manasa Kona. I am from the Georgetown University Center on Health Insurance Reform. We are a part of the McCourt School of Public Policy, and we do legal and policy analysis on federal and state regulation of health insurance as well as market trends. We publish a variety of reports, studies, blog posts, and we also provide technical assistance to policymakers. So a little bit of housekeeping before we jump into the topic of medical debt. This webinar will be recorded and posted on the Altarum website along with the slides. All lines except for the speaker's lines will be muted until the Q&A portion of this webinar. During the Q&A, you will have to dial in on your phones to be heard because your computer audio will be set to listen only. Please feel free to use the chat box at any time to type in your questions or comments. Without further ado, I'll introduce you to our three panelists today. First, we have Nicholas Cordova, an attorney from the New Mexico Center on Law and Poverty. Second, we have Marceline White, the Executive Director for the Maryland Consumer Rights Coalition. And third, we have Julia Char-Gilbert, a Connolly Policy Advocate at the Colorado Center on Law and Policy. New Mexico, Maryland, and Colorado all recently enacted legislation to better protect consumers from medical debt. I'm hearing a little bit of interference right now, so if anybody who is not muted right now could mute themselves, that would be great. Nicholas, Marceline, and Julia, thank you so much for joining us today, and I'm really looking forward to learning from you about the new protections enacted in your states, as well as any information on how you were able to support this legislation to get it past the finish line. But before I hand it off to the panelists, let's kick off with a brief introduction to the topic of medical debt. So unpaid medical bills are among the largest contributors to personal debt in the United States. According to recent data, about half the country is in medical debt, and about a fifth of the country is in collections for medical debt. Medical debt is also one of the leading causes of consumer bankruptcy in the country. Some estimates put medical debt of 11 million Americans having medical debt over $2,000 and 3 million owing more than $10,000. But it is important to note that medical debt burden doesn't affect everyone equally. There are disparities in terms of both who incurs medical debt and then who is sued in court for medical debt. First, evidence shows that Black and Hispanic or Latino families are generally more likely to have medical debt than white families. Younger families are also more likely to be affected. And then, as you might expect, families who have at least one family member with a disability or experiencing illness are also more likely to experience medical debt. Finally, recent evidence from a study of Wisconsin court records over 17 years found that Black patients and those living in poorer and more rural areas were more frequently targeted for lawsuits to collect against medical debt as well. Protecting patients from medical debt is critical for eliminating disparities and promoting health equity. But how does medical debt impact consumers? Once medical debt goes into collections, there's a chance it can end up in your credit report and reduce your credit score. The three main credit reporting agencies, Equifax, Experian, and TransUnion, recently did announce that they will no longer be including medical debt on credit reports once it's paid off, and that consumers will get about a year before unpaid medical debt even shows up on their credit report, which is an improvement than their prior policies. But it is estimated that even with these changes, 30% of medical debt will still end up on credit reports. And a low credit score can be a real problem. It can make it harder to obtain loans like mortgages, can make it harder to rent or an apartment or even to get a job. And your credit is not the only thing that can be affected by medical debt. So if a patient ends up losing a medical debt lawsuit, in many states, the court can allow a hospital or debt collector to reach into the patient's paycheck every month and take a piece of it before it can even reach the patient's hands. The court can also order a lien on the homes of patients. And then finally, medical debt can be a source of tremendous stress for families. Various regulators have tried to step in and curb some of the worst debt collection practices that harass patients, but a lot of these practices still persist in some form or the other. So how do you go about protecting patients from medical debt? Ooh, I hear an echo of my own voice. So if whoever has their volume on could mute themselves, that would be helpful. All right, so how do you go about protecting patients from medical debt? So as I see it, there are three main buckets of protections against medical debt. So first, with medical debt, as with many other problems, prevention is better than cure. Both uninsurance and underinsurance can cause medical debt. It is key for states to adopt policies that expand coverage to as many people as possible, such as expanding Medicaid, ensuring that there are as few barriers as possible to enrolling in coverage and then staying covered, whether that's through Medicaid or through the ACA marketplaces. But just having health insurance is no guarantee that a patient will not incur medical debt. High and rising deductibles and cost sharing are one of the primary contributors of medical debt as well. Policymakers need to consider ways to curb these cost sharing in order to protect people from incurring medical debt in the first place. The second bucket, in most states, hospitals, and particularly nonprofit hospitals, are already required to provide some kind of financial assistance or charity care to those who cannot afford healthcare costs. But hospitals are not necessarily following the spirit of this law as well as they should in many places. There is evidence out of Maryland, for example, that Black patients were less likely to even be aware of financial assistance policies available to them compared to white patients. States can do a significantly better job overseeing hospitals and ensuring that they're making financial assistance available to everyone equally. And then finally, a third bucket includes all the ways that states can protect patients who've already incurred medical debt to stop it from snowballing into a bigger problem. These policy interventions can include limiting hospitals and debt collectors' ability to garnish wages or place liens or report to credit monitoring agencies. And this bucket can also include transparency measures like requiring hospitals to disclose race and ethnicity data on whom they're suing for medical debt to ensure they're not disproportionately targeting some communities over others. And so with that, I will turn over to our panelists today to hear more about how their states have stepped in to better protect patients. We're going to start with Nicholas Cordova from the New Mexico Center on Law and Poverty.
Thank you. So my name is Nicholas Cordova. I'm a healthcare attorney here at the New Mexico Center on Law and Poverty, based here in Albuquerque, New Mexico. I was born and raised here in New Mexico, and I'm just so incredibly happy and proud to be serving my community and doing what part I can to make sure that, one, everyone has access to affordable healthcare, but two, people don't face extraordinary collection actions just for accessing healthcare. So with that in mind, what I'm going to talk about today is Senate Bill 71, which was legislation that passed last year in New Mexico, which we at the Center and also our partners in the New Mexico Together for Healthcare Coalition worked on and continue to work on for its implementation. So just as an overview, I'm going to talk about our coalition a bit, then I'm going to talk about a client with whom we worked at the Center, give an overview about what medical debt looks like in New Mexico, also an overview of medical debt in general, and then looking at Senate Bill 71 in particular. And just as some more background, Senate Bill 71, its official name in New Mexico is the Patients Debt Collection Protection Act. So with regards to our coalition, again, it's called the New Mexico Together for Healthcare campaign, and it's a statewide multiracial campaign of families and community organizations that work together to advance the ultimate goal of achieving healthcare for all New Mexicans. This coalition's work is driven by our family leaders across the state, whose lived experiences as community health workers and as patients inform our priorities. And so one of those priorities here, dealing with medical debt, was informed not only by our community partners, but also by a client with whom we worked. Her name's Linda. She's pictured here on this slide. Linda is a lifelong New Mexican. She lives in Albuquerque, and she's a mother, grandmother, and great-grandmother. Now, a few years ago, Linda was sadly diagnosed with breast cancer. And even when Linda thought she was going to lose everything, she thought at least she had health insurance to cover the cost of her treatment. But 6 months into receiving treatment, Linda found out she was actually uninsured. And so the hospital stopped her treatment, at which point she was facing over $300,000 in medical bills, which you can see in that picture right there. And so the hospital sent Linda to collections, where she was being pushed to pay monthly payments of $1,000. And it stopped her treatment because she didn't have a way to pay. And so after the Center on Law and Poverty got involved in her case and provided assistance, we actually discovered that she qualified for and should have been enrolled in Medicaid the entire time. And there are thousands of patients in New Mexico who slip through the cracks in our healthcare system, just like Linda, and are not enrolled in public insurance or programs that could help with their healthcare costs, which would prevent harmful medical debt and ensure providers are compensated for their care. And so what happens is, when they slip through the cracks, they end up in collections or are sued. And so looking at New Mexico in particular, obviously medical debt is a huge issue nationwide, but especially in New Mexico, where we know that 1 in 4 New Mexicans has medical debt in collections. And whereas just over 1 in 10 white New Mexicans has medical debt in collections, that number is 1 in 5 for our communities of color. But apart from sending patients to collections, we know that hospitals sue patients for unpaid medical bills. Just reiterating this point, they garnish wages, place liens on their home, and pursue other aggressive legal measures. And unfortunately, just to talk about geographical equity, the worst actors in our state are in our rural communities and are often the only options for those cities' residents. On average, we know that nearly 36% of our nonprofit hospitals' bad debt is attributable to patients who are low income and would likely qualify for financial assistance. Making matters worse, we know that over 200,000 New Mexicans are uninsured, most of which are Black, Indigenous, and people of color. And 57,000 New Mexicans are uninsured even though they qualify for Medicaid. And so what all of this shows is that there are rocks to turn over, cushions to look under, but the hospitals just aren't doing that, and as a result, people are facing medical debt. So in response to all of this, we pushed for legislation which did pass last year, Senate Bill 71, which does a lot. I'm going to go into some things with more specificity, but generally it requires these things: screening, enrollment assistance, billing clarity, and a prohibition on suing or sending low-income individuals to collections, but also reporting certain, how hospitals use certain state or local funds. And so as I mentioned, there are tens of thousands of New Mexicans who likely qualify for Medicaid but still are uninsured. And so what Senate Bill 71 does is it requires healthcare facilities, such as hospitals, to offer, and if that offer is accepted, to then actually go through with determining a patient's insurance status, screening that patient for all public insurance like Medicaid, and also the hospital's financial assistance, and then sending the results of that screening to any third-party healthcare provider, basically anyone who operates within the facility but bills independently. And then, apart from screening them, they have to provide assistance with that application. There's also some billing clarity requirements. I'm not going to go into too much detail here, but basically, when a bill is sent to a patient, they need to actually, the hospital or provider needs to spell out with specificity, you know, if you were screened, how much it's for, how much has been paid, and how much you're on the hook for. Now, I had mentioned that low-income patients under Senate Bill 71 cannot be pursued through lawsuits or being sent to collections for medical bills. We call that larger, those larger initiatives, those larger measures rather, whether it's sending someone to collections or suing them, collection actions. And those collection actions are prohibited against patients at or below 200% of the federal poverty level. And so what Senate Bill 71 does is, on the one hand, it prohibits those collection actions for low-income patients. But on the other hand, like I said, it requires screening for public insurance and financial assistance. And to implement those provisions in law, it delegated some rulemaking authority to our Office of Superintendent of Insurance, OSI. And so OSI was required to establish minimum standards governing those screening procedures. And so what they did was they required early and really active application assistance, and requiring those facilities to send that information not just to the third-party healthcare providers, but also to any debt collectors or billing departments working on behalf of the facilities. And another piece that OSI was required to issue rules on was that prohibition on collection actions against low-income individuals. In particular, OSI was required to spell out with specificity how someone's determined to have low income in the first place. And we're, after a really, really long, hard-fought rulemaking campaign, we obtained really strong rules for this provision, which requires medical creditors and debt collectors to check if someone has a low income prior to suing them and prior to sending them to collections. Because our fear was that if the onus was placed entirely on the patient, they would have to claw themselves out of the litigation hole or the debt collector hole, which is completely unreasonable. The superintendent heard our concerns as a coalition and addressed those in the rulemaking. And so what we're also happy with is this determination. When someone is determined to have that low income, that determination needs to be honored for at least 2 years, after which point that presumption of, the creditor or debt collector needing to check the income status, that kicks back in. Now, I do want to speak a little bit more just about the campaign here. I don't have just a minute left, but really our focus was on making sure that there was equity in our entire state's healthcare system. And what we did was really reached advocates across the state, particularly in our rural communities, to make sure their voices were heard, but also making sure that we brought together both patients and providers, really to cut away at the constant strategy to divide and conquer patients versus providers. And so with that in mind, I know we're going to have Q&A, but thank you so much for your time, and if you have any questions, I'm here for them.
Thanks, Nicholas. That was very illuminating. With that, we're going to move forward to Marceline White, who's the Executive Director from the Maryland Consumer Rights Coalition.
Thank you so much, and thank you. It's great to hear about all the fantastic work happening in New Mexico as well. Again, I'm Marceline White. I'm with the Maryland Consumer Rights Coalition. We're a statewide coalition of organizations and individual members, and we focus on economic rights and equity through policy advocacy, through research, and through direct service and organizing. So I'm happy to be here today. What I'm going to do is really talk about our work since 2019 working on medical debt. We've passed legislation in 2020, 2021, and just 2 weeks ago in 2022, and really talk to you a bit about the campaign and the strategies that helped us to do that. We really focused on both expanding financial assistance as well as dealing with the predatory and kind of pernicious debt collection strategies that were affecting low-income patients. So just a bit about the history of the work. We came into this from a consumer protection angle and really from work we had done in the past around debt collection. looking broadly at consumer debt in small claims courts and debt that is $5,000 or less, looking at garnishments, looking at liens. And at the same time, around 2019, started to connect with a union, National Nurses United, who was doing organizing of nurses at Johns Hopkins Hospital. And through their work organizing nurses, became aware of concerns in the community and became aware of concerns about Johns Hopkins Hospital in particular suing its workers and community members. And so we really connected in 2019 and decided to work together around medical debt. So the first thing we did is somewhat similar to what Nicholas was talking about, is really built the case. We conducted research. We have a database that is scrapable, so we could look at 9 years of records on medical debt collections, and we released this report, Preying on Patients, and I'm happy to put it in the chat later. But it looked at, from 2009 to 2018, what happened in Maryland, and we saw that 145,000 hospitals, there were 145,000 hospital debt lawsuits. And it's important to note that Maryland hospitals are all nonprofit hospitals, so they all have to have a charity care policy, and they, get a 501(c) tax status as well, and there's a total cost of care model. So this is just a map of the medical debt lawsuits in Prince George's County, which is a majority Black county that is also one of the wealthiest majority Black counties in the country. So what we found is that low-income communities and communities of color are being affected, but also high-wealth communities of color were being disproportionately pursued for medical debt as well. Overall, we saw that of these 145,000 lawsuits, the median debt was $944 that they were collecting. 37,000 wage and bank garnishments, 4,400, a little more than 4,400 liens, and more than 3,278 people went into bankruptcy. We did do research with some economists from Boston University, and through their analysis just documented statistically what we were already seeing, which is that the lawsuits were 3 times as likely to take place in low-income communities and in communities of color, communities that were 70% or more Black and brown community members, patients. What we did is we introduced legislation in 2020 and started building out a coalition that's primarily the nurses, the state AFL-CIO, consumer advocates, and our coalition members to try to use the research to put some pressure on legislators to act. In 2020, literally the day before our legislative session ended early because of the pandemic, we passed legislation to expand financial assistance and eligibility. So again, all nonprofit hospitals in Maryland, which are all hospitals, have to provide charity care, but it raised the threshold for free care from 150% of the federal poverty line to at least 200%, and also expanded reduced cost care to 200% to up to 500%, but it doesn't have to be 500%. That's an area where it wasn't as strong as we'd like. It does require that hospitals provide a payment plan for patients with incomes between 200 and 500% of the federal poverty line. It expands notice to patients of the availability of financial assistance in their preferred language. It prohibits the use of citizenship or immigration status to receive financial assistance, and prohibits the use of any questions about citizenship or immigration status when applying for financial assistance. And then our state oversight body, that's the Health Services Cost Review Commission, had to establish a process for a patient to complain about the financial assistance policies or debt collection policies. It also expanded the enforcement of violations. So if you're in violation of this act, the hospital may be fined up to $50,000, and there are fines and penalties under our state consumer protection act that they could be fined for. So that was our first attempt to expand the financial assistance policies. The next year we came back and wanted to ban medical death lawsuits altogether. So we'd introduced in 2020 an idea of banning all medical death lawsuits. It did not pass right before the pandemic. The next year we came back for 2021 and again wanted to ban all medical death lawsuits, but as a compromise, we lowered the threshold to only ban medical death lawsuits of $1,000 or less. And in part, that's because of the research that I just showed you that showed the median death was 944. So we thought that would affect a great number of people still. We did several things in the interim before our legislative session, which is a 90-day session to build support and really neutralize opposition. One was a statewide poll on medical debt, which looked at knowledge of financial assistance, the ability to cover small medical debts, and also showed broad statewide support of the legislation and different components of it. As I mentioned, we worked with health economists to do a modeling project, both on where the medical debts were occurring right now, but also the impact of banning medical debt in the state and what that would do to our nonprofit cost of care model, because there were concerns from the Hospital Association that this would ruin this fairly elaborate model that the state has of prepay in hospital for the estimated financial assistance they'll use each year. And we created a medical debt freedom fund sort of based on the bail funds as a way to just do a solidarity project in the interim and support people who had medical debt. Again, just sort of the uses of our resources. We did demonstrate through the polling there was a racial gap in awareness of financial assistance, which was mentioned earlier, a racial gap in the ability to cover an unexpected $500 bill, and in the decision of whether to forego care because of medical debt. The modeling really refuted the hospital's contention that banning medical debt would be devastating to them financially and they couldn't sustain it. And then the mutual aid project, again, provided direct assistance, and it provided and uncovered people who could testify. And similar to Nicholas, we found that many of the people who are applying for medical debt assistance because they've been sued should have gotten free care, which I'll talk about in a second. We also launched End Medical Debt Maryland Coalition, working with the labor unions and particularly a labor union of healthcare workers that staffed the coalition. And it ended up covering about 61 organizations representing more than 400,000 Marylanders with a strong community organizing component to highlight and be directed by people who had direct experience with medical debt and highlighting their stories and voices and having them serve on the steering committee and in all of the organizing committees so that those voices and needs were continually uplifted. We had people, again, doctors and nurses testifying, so again, to try to address often that wedge issue they use in the General Assembly. And this bill passed. What it does is a couple of things. It expands the timeline to qualify for free and reduced cost care, 240 days after the initial bill. Hospitals have to produce an annual report on their debt collection activity each year that's publicly posted and available to create some sunshine. You can't report to Consumer Reporting Agency for 180 days after the initial bill, which new, TransUnion and those are not requiring that any longer. We have more time now, but last year. There's no interest or fees on debt for patients who qualify for free or reduced cost care. It established a work group that required income-based repayment plans, installment plans of no more than 5% of a patient's gross monthly income that would be implemented through regulation so that everyone would have access to a payment plan going forward. Also, no liens on a patient's primary residence, no body attachments, so you can't go to debtor's prison for medical debt anymore, no wage garnishment for patients that are eligible for free or reduced cost care. There's also information about requiring a good faith effort before initiating debt collection or, again, collection actions, so that the idea is that people would get free or reduced cost care or get on a payment plan, and they had to provide a good faith effort of that before they could initiate any kind of collection activity. And then just the bill that passed in 2 weeks ago, because of the 2020 legislation, they had the oversight body had to do a report about financial assistance and reduced cost care. And what they found is that 60% of the patients that qualified for free care were sent to debt collection wrongfully. And of those, about 1% who should have gotten free care instead paid hospitals $120 million over a 2-year period. That's an estimate. But these are people that should have gotten free care. And again, because of our model, these hospitals were already compensated for covering and providing that free care. So the legislation that just passed, and we're waiting to see if the governor signs it, basically requires Maryland hospitals to make patients whole. They have to work with a number of state agencies to make sure HIPAA is protected and the comptroller's office, and they have to identify the patients that overpaid and then write them a check. It's going to cover the years 2017 to 2021, and we hope that will provide additional accountability. So I just noted some strategies for success. Movement building, we expanded the coalition to key districts where legislators resided. Having a diverse coalition of labor, civil rights, financial counseling groups, the Poor People's Movement, all were effective. And then just in terms of politics, we did a lot of work before committee hearings, meeting with members of the subcommittee, and then following up afterwards, as well as trying to make sure there were questions both for us and questions for the opposition. And obviously, because of the pandemic, there was a lot of timely messages about the need to act last year and the need now to continue to act when we look at long COVID. And I think the research also helped us just ground this in both lived experience and data that was hard to refute. So I'm happy to answer any questions as we go forward in the chat, and thank you so much for letting me share this.
Thank you, Marceline, and I cannot recommend the report that she mentioned highly enough. And she's mentioned that she'll be sharing the link with you in the chat soon, so definitely check that out. Our next speaker is Julia Char-Gilbert, a Connolly Policy Advocate at the Colorado Center on Law and Policy.
Hi, everyone, and thanks for the opportunity to speak with you today. Again, my name is Julia Char-Gilbert, and I'm the Connolly Policy Advocate at the Colorado Center on Law and Policy, or CCLP. CCLP is an anti-poverty nonprofit that does policy advocacy, legal advocacy, research, and coalition building in Colorado. And my role specifically focuses on access to affordable health care for low-income Coloradans. And I'm excited to share a bit about a new law in Colorado that helps protect low-income patients against unmanageably high hospital bills and medical debt. So I'll start by providing an overview of the problem of medical debt and high hospital costs in Colorado, and then I'll share a bit about our new law, House Bill 211198, and how it aims to address some of those issues. So understanding the problem, there are two ways that our team typically learns about pressing issues in our communities. One is listening to community members about what's happening on the ground, and the other is quantitative data that helps describe the problem. So I'll start with the numbers, and then I'll move on to what we heard from our community partners. So as the other presenters have already very eloquently summarized, we know that medical debt is a major issue, and we know that it's a burden that is disproportionately shouldered by communities of color due to systemic racism that pervades our healthcare systems and our economic systems and our society more broadly. So if you take a look at the blue and green bars here, we see that in Colorado, communities of color have medical debt and collections at nearly twice the rate of white communities. We also know that people of color in Colorado have difficulty paying their medical bills or are unable to pay their medical bills at nearly twice the rate of their white counterparts. And we know that there are significant racial disparities in the policies and the programs that are intended to shield low-income patients from high out-of-pocket costs. So here we see the eligible but not enrolled population in Colorado. These are people who are eligible for Medicaid or for SNAP but aren't enrolled in these programs. So the blue in the pie chart here represents folks of color, and the green represents white folks. And we see that half of our eligible but not enrolled population in Colorado are people of color. But people of color make up only 1/3 of the population of Colorado. So to me, these data signal that we really urgently need to rectify inequities in who gets connected to coverage and who does not. So those are some of the numbers, but we know that the numbers, of course, only tell part of the story, and we really rely on insights and expertise from community members on the ground to get a more complete and more nuanced picture of what the most pressing issues are and what policy solutions are in order. So we at CCLP partnered with community organizations that work with low-income patients every day, including nonprofits that provide patient assistance services like help with medical bills and referrals to coverage, as well as groups that do community organizing around access to affordable health care, and attorneys who represent clients on medical debt cases. And so these community partners that we were in conversation with starting in summer 2020 really lifted up the following issues. So we heard that both insured patients and uninsured patients are facing unmanageably expensive bills, both from hospitals and from providers who work in hospitals, like anesthesiologists and radiologists, what have you. And as a result, a lot of these patients are ending up in collection. And as the other presenters mentioned, we know that many of these patients who end up in collections really should have been able to enroll in Medicaid or other programs, but for whatever reason, were never connected to coverage. We heard from the community that Colorado hospitals are not complying with existing state hospital financial assistance laws, like the requirement that Colorado hospitals offer low-income patients affordable payment plans. Payment plans that are offered are often still unaffordable for patients. And information about hospital financial assistance is typically not available in languages other than English, which we know is a major barrier for many of the patients who are most in need of support. Also, like the advocates in Maryland, in addition to talking with our community partners, CCLP also conducted a survey. So we surveyed 450 low-income patients in Colorado who had recently received medical care. And the survey results really affirmed that the issues that you see here on this slide are indeed prevalent in Colorado. So the bill that we ultimately ran in 2021 was a response to these community-identified priorities. I also want to note that community partnership is really an ongoing process. So as I mentioned, our partners were engaged before the legislative session, upwards of 6-7 months ahead of the beginning of the legislative session, in order to identify those top priorities and craft a policy response. Partners were also engaged during the legislative session, not only to advocate in support of the bill, but also to inform key policy decisions, like where there was room to compromise and where we really needed to hold the line in negotiations. And finally, our partners remain engaged after session, after this bill has passed, during the implementation process. As Nicholas mentioned, the basically strong advocacy during the implementation phase has been a really important piece to ensuring that the law, sort of as it exists out in the world, is really helping patients to the greatest extent possible. So that's a bit about the problems at hand, and I want to talk a little about our policy response. So House Bill 211198 was a bill that Colorado passed last session, and it goes into effect later this year. So what does the new law do? Probably the most critical piece of the law is that it creates what we call discounts on hospital bills for low-income patients. And when we're talking about low-income patients, we're talking about any patient from a household at or below 250% of the federal poverty level, regardless of the patient's insurance status, regardless of whether they live in Colorado, and regardless of their insurance, or rather their citizenship or their immigration status. So there's basically two pieces to the discounts. First, we have rate caps. So the state Medicaid agency has to establish a maximum amount that hospitals can charge qualified patients for a service, and that agency has to post those rates publicly on their website. And second, the law sets up requirements around monthly payment plans for low-income patients. Patients can be billed no more than a small percentage of their income each month. That's 4% of their monthly household income for hospital bills and 2% of their monthly household income for bills from providers who bill separately from the facility. So those are our radiologists, our anesthesiologists, our med techs, and so on. And if there's any remaining balance after the patient makes 36 payments on their monthly payment plan, then their bill is considered paid in full. So this way, patients don't have medical debt from hospital bills basically hanging over their heads indefinitely. Additionally, similar to the law out of New Mexico that Nicholas just described, 1198 requires hospitals to screen patients for programs like Medicaid, CHIP, and hospital discounted care. Hospitals are required to screen all uninsured patients unless the patient opts out, and they must screen any insured patient who requests screening. And we hope that this will help with the eligible but not enrolled pie chart issue that I showed you earlier in the presentation. And for patients who are eligible for discounted care, the law also standardizes things. So the application and the application process are identical across all facilities in the state. The new law also sets up protections from collections actions. So hospitals have to take certain steps before sending a patient to collections, including waiting at least 6 months from the date of service, sending a notice that informs the patient about the availability of hospital discounted care, meeting all screening requirements, billing the patient's insurance, which we heard was not always happening, and providing discounted care to all patients who are eligible. And then finally, and I think really critically, the law includes multiple different enforcement mechanisms to make sure that things are happening as they should be. So the law requires hospitals to provide patients with information about their new rights under the new law, and they must do so through multiple different avenues and in the patient's primary language. It also sets up a formal complaint process with the state for when issues arise. It authorizes the state to impose corrective action plans and issue fines in cases of noncompliance. It allows patients to sue the hospital if they're sent to collection in violation of their rights. And it requires hospitals to annually report data about screening and hospital discounted care to the state. And that data must be disaggregated by race, ethnicity, age, and primary language so that the state and consumer advocates will have good information on how the law is how the new law is working in general, and also how it's working for marginalized communities in particular. So that's it from me. If I can be a resource or a thought partner, or you just otherwise want to connect, please drop me a line. I'm always happy to chat, and I look forward to continuing the discussion with the other panelists. Thanks again.
Thank you so much, Julia. And with that, we'll now be moving into our Q&A segment. As mentioned, you can use the chat box to enter your questions, or to unmute yourself, you can press *6. And please do not put us on hold. While you type in your questions, I'll start us off. Marceline, I think you mentioned that you initially wanted a threshold of pursuit of medical debt lawsuits to be $5,000, and then it was reduced to $1,000, and that was instrumental in passing the legislation. And then I'll direct this question to all three of you. Were there any other provisions that were not included in the final bill that you would have liked to see put into effect?
Sure, I'm happy to start. So we'll be bringing back the ban on lawsuits because we didn't get that. We didn't get that at all. We'd originally negotiated it down from 5,000 to 1,000, but that still didn't pass, so we're bringing that back next session. But another piece that got modified at the very last few hours was originally we had a prohibition on liens on homes for the patient, but also for any descendants. And that got modified at the end so that while the patient is alive, there can be no lien on the home, but they decided to allow, if the patient dies, that there can be a lien on the home before it would go to sale. So we're particularly concerned about that in terms of generational wealth and wealth stripping in communities of color. So we'll be looking at that again. And similarly, there were some issues around, originally we wanted to ban wage garnishment for anybody that was being pursued for debt collection, but that was a bridge too far in 2021, so we'll be coming back to that as well.
Thanks, Nicholas. Julia, did you want to add anything to that?
Yeah, I can just add for New Mexico, there are a few pieces that we had included in Senate Bill 71, but were taken out during just, the legislative process. The first of which was the definition of collection actions, again, which are prohibited against low-income patients. Just during, behind closed doors, deal making, credit reporting was taken out as a prohibited collection action. The legislator who requested that be taken out basically said hospitals don't engage in this practice, so you shouldn't prohibit it. I think we certainly disagreed with that, but that compromise helped to get over the finish line, and so we're monitoring the extent to which that is actually true. But the second piece was a prohibition on price gouging for uninsured patients. This has been a years-long effort by the Center on Law and Poverty, but also our coalition to make sure that there is fair pricing from hospitals for uninsured patients. I think that the main argument here against this specific section was there wasn't enough data to see the potential impact on hospitals, especially our rural hospitals. And so, again, just to, in the compromising phase, and this was right up to the finish line, we agreed, if this section is going to hold the entire thing back, it should probably go, and we can further study this issue and actually come back with that data to support potentially, individual legislation on this issue. But I think all of this speaks to, at least in New Mexico, I don't know how it is in other states, when you go into your legislative session, what we're doing at least is we're going all in. We're asking for our dream. We're not going in having negotiated against ourselves, because inevitably what happens is, at least in our Senate, our allies are encouraged by Senate leadership to compromise with the other side. No ifs, ands, or buts for big legislation, and so inevitably that's what happens. And it's better to get 3/4 of the pie that you went in with than really, really diminished pie that you've already negotiated against yourself with. So, yeah.
Yeah, I can jump in as well. This is Julia from CCLP. There's two things that come to mind, one from the legislative process and one from the implementation process. So initially, the act had been, as I mentioned, there's sort of screening requirements that hospitals must screen patients to see if they're eligible for discounted care and programs like Medicaid, Medicare, CHIP, emergency Medicaid. And so initially, the ask was that hospitals screen all patients who pass through their doors. And we heard from hospital representatives that that would be too administratively burdensome. So the law, as passed, requires screening for all uninsured patients, and insured patients have to ask to be screened. Insured patients who ask to be screened have the same rights as all uninsured patients, but the insured patients must know that that is something that they have to do in order to set that process in motion. And so this is something that we're sort of lamenting and thinking about a lot now as we move through the implementation process, because we really want to make sure that there's a robust public education push to ensure that both patients and patient advocates, and particularly insured patients, know about their rights under the new law and know that they need to request screening in order to sort of tap that first domino and have the protections fall from there. The other thing I'm thinking about is a compromise that's occurred during the implementation process. So something that I regret was not in our initial bill is around basically clarifying that patients need not apply for discounts or be screened for public coverage programs at every single encounter. We wanted to see basically a shelf life that lasted a year. So if a patient came in January and then again in April, that they need not go through that process again. So we wanted to ensure that ideally patients who have multiple encounters over the course of a year don't need to jump through these hoops again and again. And also, given that the application is uniform across facilities under the new law, and that the eligibility criteria and the benefits and protections are more or less uniform across facilities under the new law, we wanted patients to be able to basically have their eligibility transferable across facilities. So if they go to Hospital A in January and Hospital B in April, that they, again, need not jump through those additional hoops. And we ended up in a place of compromise with the state and the hospital representatives where eligibility determinations are good for 1 year. That's now in rule. But patients who have encounters across multiple hospital facilities, unfortunately, will potentially need to go through that process at each encounter. So something that perhaps we could have anticipated and stuck into the legislation initially as a statutory requirement, but we're doing our best to win on through implementation and rulemaking.
Thank you, all three of you. Let's take a question from our participants. Are there any federal laws that apply to all hospitals? And additionally, is there a landscape analysis of all laws such as these existing throughout the country? I might be able to help on that second part of that question a little bit. I think the National Consumer Law Center compiled some of these state laws, and I think that is available, but I feel like it is behind a paywall. Secondly, I believe Community Catalyst has put together at least a subsection of these laws. I think they've done a 5-state or a 6-state analysis of states like Maryland, Colorado, and others that have passed recent laws on this. And finally, I guess just a plug for Georgetown, stay tuned. We are planning on doing something on this soon. If you've followed any of our work on balanced billing, this is going to look a lot like that. So turning back to our panelists, I was wondering if you could talk about if there were any federal laws that apply to all hospitals that might help on this front. I mean, I know that the No Surprises Act probably went a long way in helping with this, but if there's other pieces.
Yeah, I mean, I was going to say the No Surprises Act too, which I know people, I think, are talking about later on in the chat. But there's been legislation that hasn't passed that I think will be reintroduced. I know Senator Van Hollen at one point had legislation around medical debt collection, and I think there's been other efforts as well, but they haven't passed. So I think it's an ongoing effort to address some of these medical debt abuses. And I know obviously at the federal level, at the agency level, they're trying to address it where they can.
Yeah, and
thanks. Sorry,
no, so this isn't legislation, but what we're pretty excited about is, Consumer Financial Protection Bureau announced that they're interested in potentially issuing rules bearing upon credit reporting for medical debt, just prohibiting that altogether. We're certainly going to engage with our congressional delegation to make sure that this is on their radar, but just wanted to highlight that as well.
Thank you. Our next question, every year the Loan Institute publishes the Fair Share list, tax-exempt hospitals who pay out less than received in tax-free revenue value. Does anyone happen to know if the Johns Hopkins system is on the list of hospitals not paying their fair share? I think this is for Marceline.
I don't know off the top of my head. I do know in the report we issued, we did look at CEO compensation and the percent from security care denials, but I don't know. That would be a really interesting question to find out. Thanks.
Thanks. Our next question, billing discrepancy that impacted medical debt. Provider created separate account number for the same patient and then applied payments to the wrong account but didn't catch this, and one account went into collections. Is this a common billing practice? Unique account numbers initiated with the same provider or billing network. Not only a collections problem, but from a repayment, a series of bills that could be managed monthly became several individual bills requiring full payment all at once. I was wondering if out of community engagement, maybe you'd heard of anything like that.
I haven't heard of any.
Oh, go ahead. Oh, I was just going to say in Colorado, I'm so sorry, the mute unmute is challenging. I was just going to say in Colorado, I haven't heard of this being an issue, but I would invite the other advocates to weigh in, including folks in the chat. I wouldn't be surprised if this is something that you're seeing in your community. I wouldn't be surprised if it's something that's cropping up elsewhere as well. Sorry, that's not more helpful.
I was going to say, in Maryland, we haven't seen this, but we've seen other egregious actions. We've had people that have been sued by hospitals, and they've proved, and they've gotten a judgment against them, and they've proved that they were not the person that was, it was a mistaken identity. They weren't the patient, and they refused to stop garnishing their wages. So we've seen some pretty outrageous actions from hospitals on these issues.
Thank you. Our next question is on how these protections will interfere with disclosure requirements of the No Surprises Act.
I think those are good questions. We're actually looking in Maryland at doing some community organizing and some outreach and education around the No Surprises Act in particular. But we've also got on our website a guide to medical debt as a way to do know your rights trainings and start to reach out to community members about state laws as well as the federal law.
Yeah, thank you. Moving, I think there are no other questions from participants, but to close off, I guess I'll ask one of my own questions that I was interested in. I was just wondering, so were there any allies that you found particularly helpful during campaigns? I think you mentioned consumer engagement, but I was just wondering if there were other allies that you found to be helpful.
I can just speak briefly about, in New Mexico, our experience with a few nonprofit hospitals here, which was pretty surprising given the pretty fervent opposition from the Hospital Association. We had some kind of very, very constructive meetings, I'll say actually, behind closed doors with these hospitals that produced, I think, better statutory language, but also during the rulemaking phase, we collaborated with one of these hospitals to provide public comments asking for more clarity and better protections for patients. But it definitely required a lot of trust building on our end because of that really strong opposition from the association.
Thanks, Nicholas. And with that, I think we're at the hour and at the end of our webinar. Thank you so much once again, Nicholas, Marceline, and Julia, for sharing your experiences and about your new bills with us. This has been incredibly helpful to me, and I'm sure to all of our other participants as well. Thank you, everyone, and I know that you can reach out to me, and I know that a couple of the other speakers also offered to have you reach out to them if you have any further questions. Thanks, and have a great day.
Thank you, everyone.
Thanks.